everybody. I'm super excited to have a new speaker for us this month. Dr. Hannah McLean has been a piezo wave user for many years. She's a diplomat, and she has helped us integrate the piezo wave into many practices. It was St. Francis in New Jersey, and then VOSM. And now she's doing her own thing, which is always exciting for all of us. She will be open officially on Monday as McLean Veterinary Sports Medicine. So I'm happy to have her on board to talk to us about tendinopathies. And she has some slides and a presentation for us to discuss. As always, guys, don't be afraid to stop and ask questions, because we want you to be as interactive as possible. We all appreciate your time and energy coming to join us today. And I'll turn it over to Dr. McLean.
Thank you. Thank you, Cindy. So just wanted to introduce myself, give a little bit of background specifically regarding shockwave therapy, and I'm slowly letting more people in. So I'll pause as I admit them. I was very fortunate to do undergrad and veterinary school at the University of Tennessee. I moved to Richmond, Virginia, did a rotating internship in private practice, primarily focused on neuro, cardio, emergency, and surgery. We had a multitude of practices within that business, but primarily surgery and neuro are where I spent most of my time. And then I was very lucky to return to the University of Tennessee for my residency. And that is where I was introduced to shockwave. We did a little bit during my internship with the Pulse Vet, but the piezo wave was introduced to me in 2016 through the CCRP program, and then following with my residency. And so I've been really blessed to get to use about every single shockwave unit that is on the market, including the old G10 shockwave units and the equine version of the piezo wave, and then as well as electrohydraulic units, radial shockwave units. I think the only type of shockwave I've not used yet has been electromagnetic, and I just haven't come across one of those machines in the US. And so very, very blessed to use all of those. I've been very blessed with owners that are willing to try new treatments and multimodal treatments. So I've gotten to add and subtract things from shockwave throughout my career. And I have had some really awesome mentors that have allowed me to do some picking and choosing and trying out different things. And so I don't have any really set protocols for anything. I base everything on patient response to treatment. And so I'm going to go through a little bit of how I integrate shockwave into our tendinopathy cases. I have a very specific group of patients that I see, primarily sporting dogs, high-level agility, and then I see a lot of fly ball, dock diving, frisbee dogs, and then even in the agility world, starting to move on and seeing more AKC, UKI, different dogs with different types of tendinopathies and different presentations of tendinopathies based on their sport. And so it's been really interesting movement through that in the last year. Really, the use of shockwave and supraspinatus and biceps tendinopathies is what I'm going to focus on today. That's the vast majority of tendinopathies that I see. And so that's what we'll focus on. As you guys know, 10 days ago, Dr. Kern and Dr. Tomlinson published in Frontiers a paper on ultrasonographic appearance of supraspinatus and biceps tendinopathies and their improvement in dogs treated with low-intensity extracorporeal shockwave therapy. So this is a wonderful paper, and it is just 10 days old. And so it is really awesome from Dr. Kern and Dr. Tomlinson. I'm very excited about the results. I'm very excited about how I can integrate this into our practice. And so really the biggest question for me when I saw that abstract was, what was their treatment protocol and what did that look like? And so their treatment protocol for this study specifically, all dogs were treated once weekly for 3 weeks, so 3 sessions in total. The hair remained clipped. They were all ultrasounded before, so the hair was short throughout that treatment time period. They kept all of these dogs in lateral recumbency, but again, a real huge benefit of the PZO wave is the unsedated component of that. The focused penetration depth was determined based on at the time of the ultrasound. And so they actually measured from skin surface to the lesion within the supraspinatus or the biceps to ensure that they had the correct size standoff pad for each of those lesions, which is really awesome. I haven't seen other studies do that. The treatment zone was selected based on what portion of the tendon was affected, and they used that as a kind of global 1 centimeter measurement, and then they treated 0.5 centimeter proximal and distal, medial, lateral to that lesion as well. If both limbs were affected, both limbs were treated. All affected tendons were treated regardless of lameness laterality in these dogs. Their treatment protocol for the biceps was 500 pulses per site with a frequency of 6 pulses per second. The supraspinatus tendon, based on the recommendations in the guidebook, the new user guide, was 750 pulses for the supraspinatus on either side. For the energy flux density, prescribed within a range and then applied at the highest end of range that the patient would tolerate. So when they found that biofeedback, they would continue until the patient would pull away. The energy flux density range in this study was about 0.12 to 0.17 millijoules per millimeter squared. For us with the F7 G3 probes, that's going to be anywhere from level 6 to level 10. And so pretty higher on that. If you have the G10 probe, the equine probe, that's going to be like 2 to 5. And then all dogs in this study were treated only with shockwave and exercise restrictions. There are no additional modalities used for these dogs. The results are pretty remarkable. And so when we're looking at cross-sectional area, which gives us an idea of the amount of inflammation within the tendon, they were significantly lower in the post-ultrasound than they were in the pre-ultrasound for both the supraspinatus and the biceps. The other big component of our ultrasound is our ultrasound score, and this is an idea of how the tendon looks on the ultrasound, and so how many tendon fibers can we see, how many areas of inflammation, and those are usually hypoechoic kind of foci throughout the ultrasound. And so seeing those ultrasound scores lower means that they have some more normal component of a tendon through that ultrasound. To better describe that, they did include an ultrasound here. And so this is our pre-ultrasound here. This is our supraspinatus tendon. This is kind of the musculomyotendinous junction of the supraspinatus. And then you can start to see kind of the edge of an egg here. That's where that supraspinatus is going to turn and look directly at us. And so this is kind of our myotendinous junction here. And throughout this myotendinous junction in our we have these little areas of hypoechoic or anechoic fluid accumulation throughout that, and so it gives that tendon what we call the mottled appearance. So instead of seeing longitudinal tendon fibers, we're seeing this mottling throughout it. When we look at our post, we see significantly less areas of hypoechoic foci, and we start to see more of those tendon fibers. It doesn't look like it's mottled very much at all throughout that. And this is only 3 weeks post-treatment. So pretty significant tendon fiber change already 3 weeks post-treatment. And so that's going to be 6 weeks post the start of all of this. So this is a great study, and I'm super, super excited about it. And I'm hopeful that to hear Dr. Tomlinson and Dr. Curran talk about the study a little bit more in depth. But the biggest thing as I was reading through that is, how do I integrate that into my practice, and what does that look? How does this paper change what I do on a day-to-day basis? And so really the biggest thing is to focus our therapy based on our ultrasound findings when available. And so to me, as the ultrasonographer, who's trying to convey where those lesions are, integrating measurements to those large lesions and giving a better idea of where those are within the tendon. Is it right at the origin? Is it within, for the biceps, is it right at the supraglenoid tubercle at the origin? Is it closer to the musculotendinous junction? Is it within the biceps groove? And so we can kind of give a better idea of where that is, and give a measurement of skin depth to the lesion, so we can better choose our standoff pads. For the supraspinatus, the same thing. When I have that view, where are those areas primarily in the supraspinatus of mineralization or hypo and hyperechoic change, so we can better focus our focused shockwave. The biggest thing in looking at this and reading this is to just ensure that we have appropriate anatomic landmarks, and that we all know what we're aiming for and how we're focusing that shock wave through that tissue, so that we can fan appropriately through the lesion. Susan and I were talking about this earlier today, but treatment beyond the defined lesion is super important. And so we don't want to treat just that defined lesion. We want to treat the transitional area between normal and abnormal tendon fibers as well. The hope, in my knowledge and mechanism of action of tendon healing and fibrosis, is that I want to ensure that that transition has a better or more appropriate fiber arrangement through there, so that we decrease our risk of recurrence throughout these guys. So Susan and I were talking about it. We usually go a little bit further because we fan through the entire tissue. But treatment beyond that just specified lesion, not just treating the biceps origin, treating further down the biceps origin, treating medial and lateral to the biceps as we focus in on as much as possible. Another big component of this for me was results were seen within 3 treatments, and that is less than I normally do. I'd love to hear what everybody else thinks, but we start with 4 at least before we reevaluate, and so that maybe fewer treatments are needed. And so that's something to consider. And then results seen as a monotherapy in conjunction with rest. So they only use shockwave. And so could results have improved further? Could those ultrasound scores have decreased even more if we were using a multimodal therapy? And then the age-old question of which multimodal therapy do we add in? And Dr. Tomlinson's done some fantastic lectures previously about multimodal management and integration of the shockwave there into your practice. And so those are great resources as well. But I did a little anatomy review with my own dog. So hopefully you can hear the video. Please let me know, pop up in the chat, or just raise your hand if you can't hear it. But this is my own dog, Tully. This is a model of the scapula and the humerus here, just to give you an idea of what that looks like underneath the skin. So we have our acromion process, and on Tully, that acromion process is right here. And so that's going to be one of our landmarks for determining where our spinatus and our biceps are. And so supraspinatus lives right in front of the spine of the scapula here, and his courses distally around the end of the humerus here, and it attaches just on the inside of the humerus. And so when we find that on Tully, we're going to be looking for that acromion process, which is going to be here. And so that supraspinatus is going to be just in front of that and coursing around the top of the humerus. And so we're going to have to externally rotate Tully in order to find that. So we have acromion here now, externally rotated. Now we have our insertion of our supraspinatus here. To find the biceps,
we'll go back to the model here for just a second. To find the biceps, we have to externally rotate that limb even more to find our biceps tendon here. That's going to start on our supraglenoid tubercle and then course medially down the limb and attach just distal to the elbow joint in the area of the medial coronoid process of the elbow. So in order to find that biceps, we're going to do the same thing that we did for the supraspinatus insertion and externally rotate that humerus to get to the medial aspect of that joint. On Tully, that's going to look like us using his elbow to externally rotate his limb. We're going to find that acromion again, and so we're going to find our supraglenoid tubercle. And our biceps coming off there. So it's right in this area. You'll notice that this biceps origin and the supraspinatus insertion are in a very similar area. They actually overlie each other and have different ways of movement during range of motion. And so that's why a lot of times when we have a supraspinatus or biceps injury, they tend to start to impinge on each other as they swell and have inflammation. And so for shockwave, we're going to take our head. Based on ultrasound measurements of Tully, we need about a 5 millimeter head in order to get to the biceps. And so what we're going to do is externally rotate him. We're going to find that acromion of the scapula, and then we're going to fall medially to find that biceps groove there, and we're going to treat right in that area. A lot of times we also need to drop the trode head so that we can treat that entire area. We're going to fan through there to treat that origin of the biceps.
And so that's just a little review of anatomy and fanning through that biceps. And I'm going to jump into a little case study of a sweet cattle dog named Boomer. And so, but again, at any point, jump in if you have any questions or concerns or remarks. And so Boomer's a 6-year-old male neutered cattle dog. He is a pet dog, but he has very chronic repetitive activity. He chases the ATV. He plays fetch every single day for about an hour just to tire him out so he doesn't absolutely destroy his home and drive his mother crazy. And so we saw Boomer. He had about a 1-year history of an intermittent right forelimb lameness, minimal response to multiple episodes of NSAIDs and rest. He never got better, and his owner got really frustrated. And so they came to, this was at VOSM when I was there. And so the first thing we did was take x-rays of him. He had never had forelimb x-rays taken. And we always start with those. And when we got to his right shoulder, he had quite a few changes going on at the level of the proximal humerus. And so this is his scapula coming down here. In the area of the supraspinatus, we have this mineralization, whether that was a partial avulsion or mineralization of his myotendinous junction of his supraspinatus. I'm not entirely sure. It blocked all of the ultrasound views a lot, and so we'll show you those ultrasound views in just a second. The other thing to take note of on his x-rays were this mineralization within his biceps groove. So he kind of has this modeling to his biceps groove a little bit. The biggest one you can see kind of a very focal hyper-echoic change there. And then a little bit of change to his supraglenoid tubercle. If I had his left leg up here, you'd be able to appreciate the change, but he just has a little bit of hypoechoic change to his supraglenoid tubercle in comparison to his other side. That's the other thing, is we always take both sides so that we can compare and pick up on these very subtle changes that may help us determine what the next best diagnostic for this dog is. For Boomer, we chose musculoskeletal ultrasound as our next diagnostic, and his owner, he was a great dog. We were able to do it all in the same day. And so this was his initial ultrasound. And so on his supraspinatus here, kind of this egg, this is our supraspinatus coming down, and we can see that longitudinal section there. And then it makes a turn at its myotendinous junction and then comes and faces us exactly based on the way that I ultrasound and was trained to ultrasound. And so we see this kind of egg of the supraspinatus insertion there. And so in that, we can see these hyperechoic changes, and we can see this artifact that we have of just complete blockage of where that kind of linear mineralization was within his supraspinatus tendon. The other thing to note, and you'll be able to see on his results ultrasound, but this has abnormal alignment, so I can't line up the supraspinatus and the biceps, so I had to put them in different pictures here. So this is his biceps origin here off of his supraglenoid tubercle. We have significant hypoechoic change in a moderate sized hypoechoic foci here, but we've lost all fiber pattern through this enthesis here. And the other thing to note is that he has quite a bit of fluid around that biceps tendon as well. And the biceps tendon does ride in the shoulder at this site at its origin. And so there should be some joint fluid in that area, but this is markedly more than I would expect. And so his owner had done some minor physical therapy with their primary veterinarian. They had done laser along with exercise restriction and some NSAIDs. And so when I talked to the owner about conservative management with just shockwave and the addition of laser, they decided that they really wanted to go for something a little bit more intensive. And so we talked about the treatment protocol of the combination of shockwave therapy with PRP. And I should note that in this protocol, it is not only shockwave therapy that they're receiving with the physical therapist, they're getting shockwave and then manual therapy and laser as well in combination at 3D laser with these. And so for Boomer with week 1, we started with shockwave first. So we actually, for these guys, we pull PRP, start to process that, do their shockwave, and then sedate them and do their PRP injections. Which just seems to work best for us in that order. And so we have time to process the PRP while we're doing the shockwave. And so for Boomer, we did shockwave of 350 shocks per site. And I should clarify my verbiage on that. It's 350 shocks of biofeedback. And so I fan through the muscle. Once I find an area of biofeedback, I'll hold for 100 shocks, then move to another area of biofeedback, hold for 100 shocks, and then find that third area of biofeedback, hold for 100 shocks. So it can be a variable amount that I'm shockwaving each of these sites. I'm just looking for 3 specific sites of biofeedback to treat in both the biceps and the supraspinatus. And those areas of biofeedback could be anywhere within the acute lesion, within the transition period, or even in the normal muscle if I'm changing my trajectory to move that shockwave through and they have biofeedback, I just stay there. And so those areas of biofeedback can change each time that I'm shockwaving them. But that's kind of my general protocol for supraspinatus and biceps. And so we shockwaved him, and then we did intralesional PRP. So we injected his supraspinatus on the right side intralesionally, and we injected his right biceps as well. Because he had increased joint effusion within that right shoulder, we did go ahead and put some PRP intra-articularly in that right shoulder as well. And of course, because he's been lame for a year, he had a compensatory supraspinatus tendinopathy on the left side. So we injected that left side intralesionally. We did not do an intra-articular injection on the left side because he didn't have increased effusion on that side. And so we repeat that. Every week we go through the PRP, the next week shockwave and physical therapy, the third week shockwave followed immediately by PRP, 4th week, and and just see how he goes. And again, I said in the beginning that we don't treat anything via a protocol. There's no real cookbook for these guys. And the reasoning behind that is we ultrasound them at every time we're going to do a PRP injection to determine what does that tendon look like. Are we seeing improvement in the tendon fiber pattern? As Dr. Tomlinson and Dr. Kearns showed in their study, you can see an improved fiber pattern in less than 6 weeks. And in my experience, by week 3, by that 3rd week after our first PRP and shockwave, we're usually seeing pretty significant change. So most of these dogs are getting 1 to 2. Very few actually get the 3rd PRP injection. I would say only about 30% of these dogs are getting that 3rd PRP injection because we're already seeing resolution of those hypoechoic lesions with the combination of PRP and shockwave. And so that's his treatment protocol. He did get all 3 PRP injections, primarily because he was not a very good candidate for restriction. And so his owner tried their absolute best, but he was still pulling on the leash. He was still trying to jump up on everything. And even in his crate, he was trying to dig out. And so again, he's a cattle dog that wasn't used to he wasn't crate trained or anything like that. So we did do the 3rd. By the 6th week, when we did his last ultrasound, he had improved quite significantly. And so these are his results. And the biggest thing is I put the probe on and I saw his supraspinatus sitting on top of his biceps finally in this view. And I thought, goodness gracious, it finally looks better. And then his biceps here still have some significant modeling to that tendon, but we have definitely more tendon fibers and a lot less enthesitis or inflammation of the origin of the biceps with this. I wanted to open it up to questions, or if somebody would have done something a little bit different, I'm always open to positive or constructive feedback as well.
So Leslie has a question about clipping. Now you're clipping because of the ultrasound, correct?
Yeah, so I'm of the UT school of thought. So we clip for all shockwave. We do use as much of a mobile area as possible. And so, but most of my dogs, because we're doing injections or we're doing ultrasounds, we are clipped. Susan and I have recently been using a shockwave as our for phonophoresis, and using the shockwave to push lidocaine and dexamethasone gel through. Historically, that's been done with therapeutic ultrasound. And so we have been doing that with shockwave. When we are doing those, we do completely shave the area. And so, but in between, a lot of times these dogs will go and we'll let the hair get a little bit longer. You just want to make sure you use a lot of gel for those dogs. We go through gallons of gel. So you want to make sure, and you can even use water to wet down the hair and spread the hair away from the site. I give a lot of dogs a little comb over and shave just below, and then let the hair fall back. Luckily, most of my dogs are sporting dogs and not show dogs. So I'm blessed for that. Most people don't really care too much. Yeah.
If you do have show dogs or owners that do care, I will say that we do have quite a few people that are not able to clip, and with plenty of gel and maybe using a little extra energy, they do get results. It is a customer practitioner choice, but clearly the textbook says clip. I don't want you to turn away a possible treatment for not clipping, because you know, Dr. Taraka and some who cannot clip still do get good results.
Can I tag on a second question with that as
Yeah.
well? Sorry,
Absolutely.
we don't have diagnostic ultrasounds. We do have the piezo wave, and we've been using it with a lot of gel. So I haven't been clipping up to this point. So I just wanted to be sure, as long as we're doing that. But the second question was on guessing depth of treatment, because I'm not having diagnostic ultrasound, I'm trying to just go by biofeedback, and sometimes I'm jumping between a 5 and a 10.
Mhm.
Like to see, I don't know if you could speak on that, if we're
Yeah.
basing it on reaction.
Yeah. So a lot of times I'm using palpation to try and determine that depth. As you can tell, my dog is a little bit over conditioned. I can't for the life of me keep him an ideal body weight. And so his depth of penetration, even in his over conditioned state, is still 5. So I think staying between that 5 to 10 is going to be a really good thought. I'm going to step back and grab my model just really quick. These models are made after 60-pound to 70-pound labs. And so when we look at this, we can see how superficial that biceps tendon and supraglenoid tubercle are. So really what we're trying to determine is how much subcutaneous tissue and skin depth. And then if we're having to use a lot of gel over the hair, using that to compute that as well. But I think you're doing a great job of using that biofeedback. That's really what we're going to be looking for. And somebody also was asking about clarifying what biofeedback is. And I think we've used that term for a very long time with the PCO wave, because that's really kind of what sets it apart is with other electrohydraulic machines, and I know there's a new one, but they require sedation, and so you're not getting that feedback once you get on the pathologic tissue. But the feedback that we're looking for is either muscle spasm or a pulling away of the dog away from your trode. So when you put the pulse vet or when you put the PCO wave on your arm and you go down a normal tissue until you get to an area of either where your bone is very close to the surface, and so that tissue density interface is really close to the shockwave standoff pad, or when you get over an area of pathology, you automatically start to feel this pins and needles type feeling. And so that is the biofeedback that we're looking for. So the pulling of the leg away, muscle spasm occurs quite frequently when we're treating the supraspinatus and the biceps. And as we push medially, you get biofeedback just from pressure into that medial shoulder as well, because and we haven't talked about medial shoulder today, and somebody else can touch on that, but really that focus on that supraspinatus and biceps tendon, we tend to see quite a bit of spasm as soon as we get over the area of pathology. We don't have a therapeutic ultrasound because we've had such significant results with our shockwave. And so, but we are starting to see more and more of our lumbosacral dogs and sciatic neuritis with piriformis syndrome. And we're diagnosing that via ultrasound. And then hopefully, if we can talk someone into it, a dynamic CT or MRI to go along with that so we can determine piriformis is a secondary or a primary cause versus that. So really for photopheresis, we're still using the same photopheresis gel. We're clipping the hair. We're using the same photopheresis gel of the lidocaine and dexamethasone. You can get that. We get ours from Wedgwood. I found it described in human literature once, and I haven't seen it described in veterinary literature, but the mechanism of action is still the same. We're still using a sound wave, this one a much more focused sound wave, to push that photopheresis gel through tissues. We're having very similar, if not a little bit better, in my opinion, results. And by results, I mean a faster return to non-skipping. And so a faster return to them being more comfortable. The question is that photopheresis because we're treating the sciatic neuritis better, or is it because we're using the shockwave to help heal the tendinopathies of the piriformis and typically the middle gluteal that we also see associated with that? And so that's really kind of what we're thinking and trying to move forward and see if that makes a big difference for these dogs.
I know we've seen super results just even unclipped treating through the sciatic notch on like toe drop and some crazy things. So I think the neurology is going to be amazing in another couple of years to understand more.
Yeah.
On the biofeedback, I would like to just also add that as we are evolving, and there's no right or wrong way to use the piezo wave, but the other publication that is merely case studies that Dr. Owen put out in February, I believe.
Yeah.
She uses super low energy, and I have done some work with her, and her biofeedback is literally the dog looking at you. And telling you that they feel it. So there's a biofeedback can be a large range, and there's no right or wrong way. But we can see as little as the dog saying, "Oh, I feel that." And for you as practitioners, I want to encourage you all to feel it on yourself. And when you feel that, wow, that's what the dog is reacting to.
My own dog, who gets shockwave every little bit for his hip OA and just some back stuff. He's got he's 13-year-old golden. His spinal arthritis is just would make you want to cry looking at the x-ray. But his biofeedback, because he doesn't really give me a lot of feedback ever on exam. That's why I see Susan for his PT. He does all he does is lick his lips when you're at a point of biofeedback. And so it can be very small, and it's very dog dependent. So that's a great point.
I guess I was just going to ask you again with back to like the original topic. I, like you, kind of do the 4 like weekly sessions. That's what I've done, and then reassess. It sounds like my treatment protocol is very similar to yours, the way I've been doing it before this study. I guess, are you thinking about still doing that? Although you can follow up with ultrasound and I can't.
Yeah.
I guess mostly mine's just based on exam and reactivity with palpation.
Yeah, and truthfully, it takes an hour to do an appropriate musculoskeletal ultrasound on the shoulders. We do both sides, and so it's not something that we do, every week with them, unless we're doing the PRP. And really, that's because I'm going to do an ultrasound guided injection anyway. I might as well take a general look around, and so. It would be hard for me to add in an additional ultrasound at 3 weeks to see if we see improvement. That's an additional cost for the owner. And I don't know clinically if I would change up and make my treatment period any shorter, because no matter what, my dogs are resting for 12 weeks before we start return to sport. So our return to function for tendinopathies for every dog is at least 12 weeks. And our return to sport is an additional 6 to 12 weeks, depending on the sport, depending on the level. And so I don't want to shorten that time period anymore, because we would get pushed and pushed and pushed and pushed and pushed to push this dog back to function. And then we're going to see even more recurrence of lameness, even more recurrence of tendinopathies. It's really amazing once you're able to add in the diagnostic ultrasound component to see how many of these sporting dogs, and even pet dogs, even my own dogs who do absolutely nothing but play fetch in the backyard and hike with me on the weekends, they all have these chronic supraspinatus tendinopathies with these mottled supraspinatus. And even in sporting dogs, we see that as young of an age as 2, we start to see changes in the supraspinatus. And so it's one of those, do I think that this is something we could truncate our treatment protocol with? Not really, very much. So I'm still looking at 4 to 6 sessions. And then most of our dogs end up on a maintenance protocol of shockwave. In truth, all of these, just like these dogs go to see their massage therapist and their chiropractor, they also come to see us for shockwave on a maintenance schedule. It's very rare that we get them completely out of everything where they don't have any recurrence or compensatory pain.
That makes me feel good, because I usually can't get rid of them totally.
Mm-hmm.
About once a month on average, I think some of them come back, depending on what they're
Yeah.
doing. Okay.
Yeah.
Thank you.
Hannah, do you have the linear probe? That was one question I had.
So the last two previous places I worked do have the linear probe because I bought them for them. But we don't have the linear probe here.
Thinking of the phonophoresis in the large area, that the linear probe would be
Yeah. Amy, did you have a question?
I got here late, so I don't even know exactly which joints we're talking about.
Yeah.
And were you talking about shoulders at all?
Yeah, primarily shoulders.
Yeah. Have you ever like hobbled patients when you're doing the MyAct?
Yeah, so we try to avoid medial shoulder, but we'll talk about it.
Okay.
So for these dogs, we had a really great conversation at the ACBSMR conference in April about how do we treat these dogs that have high abduction angles as well as supraspinatus and biceps tendinopathies. And Dr. Tomlinson presented, I know I've said her name about a million times in this, sorry. Dr. Tomlinson presented her way of dealing with these medial shoulder plus supraspinatus and biceps dogs. That I think that is going to be my new way to adopt. Everybody has a little bit of a different opinion. But when it comes to these guys, my primary focus is going to be supraspinatus and biceps tendinopathy and treatment of that. So I'll initiate a treatment process for that biceps and supraspinatus tendinopathy. Once we have a good hold of that supraspinatus and biceps tendinopathy and we see fiber improvement on the ultrasound, then we can assess that medial shoulder. And whether that's assessing, I like to use needle arthroscopy to assess and determine the severity of the tear to the subscap, the severity of any fraying of the MCL, and so, or the rotator cuff or the subscap or any of these things. I like to assess that via arthroscopy. I am not trained in radiofrequency like the CNAPs do at VOSM. And so I truly just use shockwave and PRP, or if the severity of the medial shoulder lesion is severe, we can look at severe but stable, we can look at stem cells. If it is severe and unstable, they get referred for a tightrope of the medial shoulder, with a distinct understanding that that dog is no longer going to be able to return to its level of sport prior to. And so once we assess that medial shoulder and determine the severity of the lesion, we will add hobbles in. But I've had the experience of watching these dogs and rechecking these ultrasounds of the dogs that have been in hobbles. Every dog that had a grade 1 or a mild supraspinatus tendinopathy after 6 weeks in a hobbles has grade 2 tendinopathy. All of them are worse. None of them improve with hobbles on. So I really liked the presentation that Dr. Tomlinson did that showed, hey, let's treat these tendinopathies and get a better get a better hold on these supraspinatus and biceps, and then we can assess the medial shoulder. A lot of times because that biceps starts inside of the shoulder, the medial shoulder looks better on ultrasound and less thick on ultrasound by the time I'm done treating the biceps. And so many dogs don't actually go into hobbles unless they have a very high abduction angle and pain at end range. And that's my biggest thing, is pain at end range of that abduction angle. I've got this sweet dog, this sweet little mini Aussie that's got a 32 abduction angle on his left side, but he's not painful at all, and a 23 on this side. And every time I scan him, he's got a thicker medial capsule on that side, but he's never been painful. So we're just going to treat his tendinopathies first.
And how much activity restriction?
So all of these dogs are strictly restricted for 12 weeks throughout this process. So 6 weeks of direct intervention, and then 6 weeks of additional intervention if we want to continue, if we need to continue shockwave based on their physical exam or their ultrasound. But all of these dogs are restricted for 12 weeks. That to me, strict restriction just means no running, jumping, playing, no off-leash activity outside. Every one of these dogs has a home exercise program that they do twice a day. And that exercise program usually takes between 15 to 20 minutes to complete. And so they're doing a lot. We are not restricting them in the sense of in a kennel, out to go potty and back inside the kennel the whole time. We're just restricting them from running, jumping, and playing. And then it's a lot to ask an owner of a home exercise program twice a day that is of that length. But we've found that the more they participate in the home exercise program, the faster their return to sport is after that 12 weeks of restriction.
Can you explain a little of the exercises that you prefer for the biceps and supra?
Yeah, so we're looking at eccentric contractions for biceps. And so we want to make sure that we focus on exercises that do that for biceps and supraspinatus. And so the exercises change every 4 weeks throughout the process, but the first 4 weeks look like a lot of static standing with weight shifting, a lot of weight shifting. We don't do a lot of play bowing or sit to stand. We do a lot of static stretch. So it's not static stretch, but active range of motion stretch. So not shaking, not having them do a wave, but to have them reach forward and touch something low, and then moving that from side to side to work on their shoulder extension with abduction and adduction, and then touch medium. But again, we're really focusing on stability and maintaining that kind of movement through that medial shoulder as well. So we don't do a lot of lateral motion with the exception of static weight shifting. And then we do a lot of legs up elevation or paws up elevation, so that we can really have them focus on what they're doing with their front limbs while they're offloaded onto their hind limbs.
I'm curious of the exercise programs that go along with it because I don't spend enough time in the clinic.
Yeah. Yeah. Well, and it depends on how each dog does each exercise. So we use the online Physiotech platform to make these exercise programs. And then I highly encourage owners to send me videos of them doing that exercise, because it's very patient based. And so if we have a really energetic, driven border collie that's, can't just reach out and touch something low, it's going to do this every single time where it's just reaching up and like slapping it. I don't want it to do that exercise. So we do have to be a little bit more patient dependent on those exercises.
When I'm thinking, like, for me, I'm quite new to the MyAct. We just got our unit. And one of my questions is, like, how much of the length of the tendon, like if my focal point is quite small, like how much of that tendon, which in my mind, could be an inch, a couple inches in a big dog, and I guess maybe this was part of the question about the linear probe, but am I trying, and I'm sorry if I'm asking things you've already said, but am I trying to address it? Does it make a difference? And do we know?
And so really with ultrasound guidance, that makes it easier, right? Because I'm able to tell you, hey, there's a lesion 1 centimeter distal to the supraglenoid tubercle, so you know exactly where you're going, right?
Mm-hmm.
When you don't have that information, I treat the entire tendon and fan through, because we don't have that information for everyone. Ultrasound is not an inexpensive modality, and so we treat that entire tendon. So from the supraglenoid tubercle to the musculotendinous junction, all the way down. And so for most of my 40-pound dogs or so, which is 44.6 is what most of my border collies weigh in practice, those tendons are about 2.5 centimeters long. And so you can just treat down through that biceps groove, and pretty quickly after the biceps groove, if you have the shoulder in a little bit of flexion, you'll be at the musculotendinous junction in most dogs. And so you can really use the edge of that biceps groove to determine how far down you should treat. For the supraspinatus, you saw how big they can get. They can get huge, and they can displace the biceps, and they can be gargantuan. So I think as long as you're on that medial aspect of the humeral head there, and you're externally rotating the limb to get to that, you can fan through that entire thing and just find your areas of biofeedback. You'll never be able to treat the entire tendon of an inflamed supraspinatus in one treatment. It's going to take multiple treatments to get each of those areas.
And what about the subscapularis?
Yeah, so you have to externally rotate even more, and so I don't do that unless I have a dog that has an increased abduction angle and pain. So I treat as far through the supraspinatus, and with the angulation of the probe aimed kind of back behind the humerus as much as possible. I can treat that subscap as much, but it's very difficult to kind of solidify where that is. I'm treating my subscap when I treat my supraspinatus, and I fan through that.
Right.
I should also point out that I also treat the teres and the infraspinatus and the caudal glenoid and the caudal humeral head in every single one of these as well. So it takes a while. It takes 20 minutes or so to get all of that done.
I think we're all starting to recognize going beyond just the tendon and into all the kinetic chain. It's a constant question because it does take a little longer. The fascination with Dr. Tomlinson's and Dr. Kern's paper is that they stuck right to the lesion, and maybe a tiny bit above and below, and they did get great results. Now, overall, would it have been faster? Would it have been? We don't know. And I think the time frame is another thing of and how many treatments. I agree with you then that we have to have a healing period no matter what. If a patient is on a tremendous budget and this becomes a financial issue, I'm not at all against starting to spread the treatments out over that healing period, if that makes sense. Because in theory, once we've initiated it, the healing, it's initiated and we can spread it out a little bit more. But we always have to be careful of pain relief versus tissue healing. And if we just stick to the pain relief, we can get in big trouble. I think we're all aware of. So, yeah. Awesome. Well, I really appreciate everybody's time. Any final questions? And we'll let everybody get on to their next part of their day. This will be posted on the users forum on the website with all this great information. And I really, really appreciate Dr. McLean's time and energy. I wish we could all learn to ultrasound. That's my next project.
My project this year.
One project at a time, but I just think it's fascinating data for us to have. Super exciting. We're gonna learn a lot more in the next near future with all these adaptations and great sonographers out there. So I appreciate it all, and have a great night, everybody. Let us know if you have any questions. I can connect you to Dr. McLean, and super excited for your new business.
Thank you. Thank you, everyone.